can I now invite Dr. Sushmita Kaushik? She will be speaking on cataract with congenital glaucoma. So we can take up one question. So I would like to ask Dr. Ankur, when do you prefer trab over combined phaco-trab? In which scenarios?
The scenarios where we have a very advanced glaucoma and a very little amount of cataract. Because here the issue is you have to have the control of pressures more as compared to what we think of in a combined surgery. Because combined surgery can have more of inflammation, sometimes hypotony, and risk of trab failure is more. And as Dr. Shalini said, that the outcomes in terms of refractive error and surgical risks are also more. So such patients, I think it is better to control glaucoma first and then plan for a cataract surgery in the second time.
So very advanced glaucoma.
Yeah, very advanced glaucoma.
Okay. So Sushmita, please.
Yeah. Yeah, can I get a pointer, please? Thank you. At the outset, thank you, Dr. Sunita, and thank you, AIOS, for this opportunity. And thank you in a cataract and glaucoma session for bringing in the babies as well. So in the next couple of minutes, we'll look at coexistent congenital cataract and congenital glaucoma, which means we had both when the child was born. But then there are also situations of cataract after glaucoma surgery, and there's also situations of glaucoma after pediatric cataract surgery. So you might get a child with both glaucoma and cataract in any of these three situations. Now, a congenital cataract with congenital glaucoma is rare. It's not common. So one of the things that we've learned is intrauterine infections in India is something to talk about. And rubella syndrome is not something which doesn't happen and doesn't cause glaucoma, even though we just think of cataract and salt and pepper retinopathy, but glaucoma is very, very real as well. The other things are a hereditary cataract with glaucoma or an oculocerebrorenal syndrome of OE, which are easy to pick up because they're so obviously syndromic, but it's not so common. And the other that can happen is non-acquired ocular anomaly, such as aniridia or in PHPB. So these are the other non-acquired ocular anomalies which can cause glaucoma, and they can have cataract as well. So we'll just look upon the rubella story. We chanced upon a coexistent cataract in a newborn glaucoma. And you can see when we looked in through the microscope during the EUA, we found these things were white. We immediately brought in our UBM. And sure enough, there was this classical nuclear sclerosis, or a nuclear cataract rather, in this baby. And then we realized that we haven't even been looking at it in all these years. When we tested rubella, it was IgM positive, which shows infection. And we thought we must tell the world that, and we published this, actually made it to the cover, as to the fact that in newborn glaucoma, we can't afford to forget infections. But then that question remained, so we thought we would look at our newborn babies. So we looked at infants less than 4 weeks between about a 15-month period of every newborn baby that came to us with glaucoma and completed a 6 months follow-up. So 27 babies, 7 of them turned out to be rubella positive. Now remember, rubella is not part of our usual workup for newborn glaucoma, but when we did this, 7 of them were rubella positive, 13 eyes actually, and 20 were rubella negative of them. And all those who were rubella positive had significantly smaller eyes, and they had a significant cataract. Of course, all of the rubella ones had the cataract, and the corneal diameter was smaller. So what we learned was that if you have glaucoma in a small eye, think rubella. That's one thing, because, and even in a normal eye, because they won't present to you with ophthalmos. They're going to present to you with a normal eye because they're usually smaller, and the glaucoma might make it almost normal. The other thing we noticed was those who were rubella negative, these are the babies who were rubella negative, cleared as they usually do. But the ones which are rubella positive, the cornea never clears because of a rubella keratopathy. So don't go ahead thinking that it's an intractable glaucoma and redo surgeries, because these corneas are not going to clear. These corneas are white because of rubella keratopathy, and they require a keratoplasty. The other thing we learned was there are systemic associations which we don't routinely look for. We had a heart disease in 3 of those babies, one PDA requiring surgery, one atrial septal defect, and one ASD, VSD, and a PDA. And one of them had a hearing deficit and was much better with a hearing aid. So we realized that there are some children where we might just send them off and say they're developmentally delayed when they're not. So these were the learning points of rubella. They're phenotypically different, and we shouldn't rule out their systemic associations. There are some babies that have come to us with hereditary cataract and glaucoma which are not rubella. These are ophthalmos and cataract, systemically normal, and genetics reveal no pathogenic variant. I don't have an answer to what these are, but we've done bilateral goniotomies in them. But the cataract was really right dot in the center, and so our pediatric ophthalmologist said that there is enough clear area around this dot-like cataract in the center, so they haven't undergone surgery as yet, and their vision is all right. So you can see these children are looking straight in at you, and since it's all right, we are watching it. Of course, aniridia, it's known. Usually when you have a cataract, it's superiorly subluxated. PHVV, again, is in a smaller eye, but that's usually unilateral compared to rubella. The other thing is cataract following glaucoma surgery. Iatrogenic, I've done this in my early days of goniotomy when you nick a lens. So now we've learned better to put in viscoelastic and make the anterior chamber really deep before doing a goniotomy. Always make the ports with the eye in the primary position. That's something that we learned. We tend to move the eye away and then make the ports, and that might nick the anterior capsule and a cohesive viscoelastic, but it's also possible while doing a combined trab with a poor view of the AC. And I did this in this baby. And you can see on the UBM, I've actually nicked the anterior lens capsule and caused a bit of a cataract there. Who is at risk once a pediatric cataract surgery is done? Those with smaller eyes, the age of surgery less than 6 months, and this, mind you, is because the trabecular meshwork development continues till about 8 or 9 months. So if we are going to remove the lenses early, the lens is a regulator of anterior segment development. And then the trabecular meshwork does not develop, and that's what the IATS has told us now, that the smaller children are the ones who are going to develop a cataract, glaucoma after cataract surgery. Use of trypan blue has been found to be significant for development of cataract. Of course, re-interventions, that's easy, and placement of an IOL. Once it happens, there's no complacency. If you see an eye like this, which is steamier compared to this, even if it's a small baby, don't let go. Iatrogenic glaucoma has to be tided over a long, long lifetime. So we need to catch these early. So if the cornea doesn't look as clear as you think it would, please think of glaucoma. Medical management, plus minus, if you can get away with the iatrogenic ones. Surgery depends on the pressure and disc damage, whichever is, usually we start with angle, then a trabeculectomy, then a GDD, and then maybe a limited DLCP. Be alert. Now this father is aphakic and has a daughter where the cataract was detected early and had infantile cataract surgery at 6 months. Presented to us 8 years later, pseudophakic with PCO and a ophthalmos in the left eye. Now since the father was aphakic, the cataract surgery was done, but nobody thought of checking the pressures of this girl. And she's landed up with ophthalmos already. So this is something which we need to take care of, because in an elastic eye, remember, the intraocular pressures may not be recorded high simply because the eye is expanding under the influence of the greater pressure. So if you don't look at axial length in a small baby, you might be missing the glaucoma, which is what happened with this child. Right, so you can see the disc is already here. We could have probably stopped it if we had been vigilant when the child was operated at 6 months of age. So in a nutshell, with glaucoma and cataract, look for a cause. Iatrogenic happens, but it's unacceptable. And glaucoma after pediatric cataract surgery may compromise an otherwise excellent outcome. So look out for pressures, look out for axial lens and the discs diligently in every child that undergoes cataract surgery. Early ocular hypertension, you can treat it medically, but once there's disc damage or ophthalmos, they usually require surgery. Thank you, and I acknowledge all my residents who work day and night to help me put these babies and these children together. Thank you.
Thank you, Sushmita, for an excellent talk. Just one question. Yeah. Do you ever combine cataract with glaucoma surgery in children? I'm not talking about developmental, but the acquired ones, say steroid-induced or traumatic, when they have coexistent cataract and glaucoma.
I've probably done one or two where it's obviously cataract and you have GA and there is glaucoma. So, but then there we've combined a trabeculectomy with a cataract surgery, and it's easy because you just need to do an IA and put in a lens. But rarely you would like to, most cataract surgeons would like you to bring the pressures down, make the cornea clearer, because in small children, when the pressures are really high, the cornea becomes steamy. So we would like to control it first and then do the cataract surgery.
There's one more question. You said about the rubella positive kids. So do you recommend that we should be testing, say suppose if a child is born and right that time the child is rubella negative and the glaucoma is rubella positive and the glaucoma is not there. So how long do we need to follow up these cases so that the glaucoma may develop later in life? Is it a possibility like that?
No, a normal child with no glaucoma you're talking
Yes,
about?
rubella positive child.
Okay, a rubella
No
positive
glaucoma at
child
birth.
with no glaucoma,
No glaucoma
at
at
birth.
birth.
Yeah, good. Yeah, I suppose it's a good idea to follow. See, what happens with rubella is there was this big pandemic of rubella in the 1930s, and when a lot of babies died, and when they did post-mortem of these eyes, a term baby's eye, trabecular meshwork, was in a rubella positive baby was similar to that at 6 months of age. So if there is no glaucoma when at birth, it is unlikely that any more glaucoma would be due to the rubella, because the arrest would have happened and it would usually. So it's newborn glaucoma that we don't think of rubella. The converse, I would say, is true. Every newborn glaucoma less than 4 weeks warrants a rubella investigation.
Thank you.
The other way around.
Thank you, ma'am.
Thank you so much, ma'am, for your wonderful